Hey everybody, my name is Alexander Simmons. I'm a current 7th try student, and my father's a chiropractor, so I was raised in it obviously, but there's a lot of people that were raised in a chiropractic household that aren't chiropractors. So what really led me to the profession is I have severe peanut allergies, and I have had multiple reactions as a child to peanuts, and through chiropractic care I was never needed to be given a EpiPen or anything like that. I've never had any drugs or any vaccinations my entire life. So that is something I'm like super proud about because that's only through chiropractic care. So without that, I definitely wouldn't be alive here today. So it's a pretty big conviction of mine.
That's awesome. I'm John. I am a 8th try. I am also, my dad's a chiropractor. Actually, my grandpa and great-grandpa were also chiropractors. So I'm now going to be 4th gen, which is kind of cool. And how I came in the profession, like Alex said, not every chiropractic family becomes a chiropractor. But after undergrad, it had always been an option for me. My dad never pushed it on me or anything. And after school, I was playing football. I wasn't focused on a ton of what I'm going to do after school. And I decided it's time to figure it out. I started shadowing some other chiropractors that aren't my dad, make sure that it's not just him, but it's like the whole profession that's cool. And yeah, it turned out to be, obviously, so I shadowed, 3-4 other guys up in the Twin Cities, and they're helping a ton of people out, so I was like, yep, I think it's the right thing to do, so came down to the homeland. That's it.
Oh, your hands are sweaty too. I love it.
So my name is Ben. I am in 5th try, so I'm the young one up here.
I like that.
So my mom actually worked for Palmer Grad. She wasn't a DC, but she had worked for a Palmer Grad. So I grew up seeing the chiro since I was a little baby, and kind of just what I grew up on. And then I think like the big turning point for me was I had some sports injuries during football and baseball, so that was like the biggest thing that helped me get back on the field quickly. And I kind of just knew from then that I wanted to be able to help out people, whether that was like athletes or just people get back to life right away, as quick as I did. So that was like a big turning point for me. Kind of led me to this.
Awesome. So, I would just want to point out that you guys have matching tops and you guys have matching bottoms. Thank you for coordinating that. I like to find patterns in life. I think that's pretty awesome. All right, so why don't you start off and tell me, how do you view chiropractic and how do you view our profession and how we deliver chiropractic care to patients? What's the best way in your opinion?
The best way, that's kind of a loaded question. We have such a wide scope of practice that there's a lot of different ways to be a chiropractor and a lot of ways to practice. To me, chiropractic care can be anything that treats the neuromusculoskeletal system and any dysfunctions within those body organ systems, if you will. And I think one of the main quotes I guess I like about chiropractic was a BJ quote about not treating the disease or the symptom to match, or not treating the disease or symptom, but rather treating the organism to build up and be able to withstand the environment, rather than treating the organism or the symptom of the disease. You know what I mean?
So how would you deliver that, do you think? You said it's a whole body thing. When you say whole body, what do you mean by that?
Yeah.
What does a chiropractor do to treat that?
A chiropractor can do a lot of things. I think first and foremost, what chiropractors do best is adjust. And then there's a lot of other things we can do too. I think a really good way to deliver chiropractic care is to use a rock solid assessment. There's no better, like someone does something best versus not, but I personally use a lot of movement analysis. I think movement-based pain requires movement-based analysis and assessments, and then that can really key you into areas of dysfunction, which aren't always the source of the pain or like the site of the pain, but they can be from a different source. And I do think a good way that chiropractors deliver care, a good like factor or like characteristic of chiropractic care is that each patient is very unique. Our little slogan that we use a lot is N equals 1, meaning people presenting with similar case, like pain symptoms and history and stuff like that, can require completely different treatment to address what's actually causing their pain. So I think the chiropractic profession is top tier in terms of treating each patient as very unique.
How would you describe what a chiropractor does, and what's the best way, in your opinion, of how to deliver that kind of care?
Yeah, so something I think that to clear up as well is like a lot of terminology. So like I'll be like using terminology that a lot of people probably haven't heard before.
Yeah,
And
lay it down, dump it down for us.
yeah, so I'll be very meticulous when I use the word treatment, and I'll just put it at that. So what we do, specifically our position, for those of you that don't know, knee, chest, upper cervical, we analyze the nervous system, and that is the really most important aspect that we're looking at, since it does control and coordinate all bodily system and functions. So we analyze the nervous system, and when there is interference in the nervous system, particularly in the upper cervical region, we perform a adjusted thrust in hopes of taking pressure off of the nerve or whatever, correcting the interference that is present that may or may not produce symptoms, and then that will give the body the optimal ability to adapt and heal itself from there on. So it's more of a, instead of a treatment basis, it's more of a deduction thought process.
So we're all going to be chiropractors. Everyone in here, we're all going to do our own thing. You guys are doing your own thing, and what I want to drill down to is what exactly is it that you do? Okay, you said movement-based assessment.
Part of it.
Do you care? So, do you care about the movement of the body?
I think that chiropractic isn't necessarily concerned with what the chiropractor cares about necessarily, because chiropractic isn't an opinion, it's like a principle. So the principle of chiropractic, it's like a law, universal law, like gravity. So when there is
Keep it to the tour. Keep it to the tour. Just talk as the tour, not as the opinion.
Okay, so yeah, I think movement's really important. I work out all the time. I'm in the gym constantly. I wrestled in undergrad. I've actually torn my labrum, and I've had a reverse Bankart fracture on my inferior glenoid, and I've fractured my humeral head in the same position as well. So I mean, like, I definitely have a good understanding of what rehabilitation and movement can do, for sure.
Is there limitations?
To movement?
Well, I want to say, because I want to drill down to the knee chest. Is there limitations to what we would call the movement assessment, a movement-based assessment versus and delivering chiropractic care in that way?
Yeah, I would say there's limitations to anything, of course. However, I would say the limitations would be if someone is fully functional. I guess I would say, I don't know what the analysis would consist of there. Whereas with us, since we're not concerned with symptoms, someone could come in and give us zero history, and we would be able to analyze them personally to them, because every patient is different, I agree with that. And we would be able to help them still. So I think that it gives us a big advantage, because you can help people that aren't able to even articulate properly what is happening with them, because we're looking at it from a deductive approach by looking at the nervous system.
So, let me ask you this: is this a yes or no question? Is every person in the world a chiropractic patient?
A candidate or a chiropractic patient?
Should be a chiropractic patient.
Under care, yes.
From your movement assessment, is that fair for me to call it movement assessment? And I'll just call you knee chest? Is that fair?
Yeah, knee chest is a broad spectrum, but I would prefer like KCUC, but yeah.
Okay.
Yeah, I mean, movement assessment is just like part of what we do. It's not like I'm just watching someone move and that's my scope there.
Why do you watch them move?
That's again part of it. It's part of the piece of the puzzle to key into what areas of the body are functioning properly per se, or maybe what I'm always looking for is big asymmetries from side to side or big limitations from the baseline. Again, keeping in mind that everybody's unique and someone's decreased range of motion might be their normal, or someone's increased range of motion might be their normal. But that's, I guess that would be answering your question, is sometimes we use movement analysis for those reasons.
So the same question, is every person in this, on this planet, minus the astronauts floating around the ISS right now, are they all chiropractic? Should they all be under chiropractic care?
I mean, I don't think there's a person that wouldn't benefit from chiropractic care. Agreed. Should everyone go to their chiropractor? I mean, I'm not gonna say someone has to go pay money to see somebody if they're living just totally fine.
So what I'm trying to pull out of this, you guys are really nice to each other. Other people are.
If you want, we can continue dialogue. I have a lot of points
Yeah,
I'd like to.
because what I'm hearing is, you're treating more injury. Maybe there has to be an issue, right? We can say thoughts, traumas, and toxins, right? Would you agree with that?
Yeah, absolutely.
Would you agree that we treat thoughts, traumas, and toxins?
No, I wouldn't agree with that.
Ooh, so we got some, here, this is what I want. I want the difference.
Yeah.
I wanna know, not what's the same, I wanna know what's the difference. So why do you say no to thoughts, traumas, toxins?
So there's a big misconception with chiropractic that thoughts, traumas, and toxins cause vertebral subluxation. That's just not true. A thought trauma, well, it's traumas, toxins, autosuggestion is what D. Palmer referred to it as. The inability to adapt to those is what causes a vertebral subluxation, and we don't treat that because that may or may not produce symptoms, right? So you can only treat symptoms. Treatment is medical care given to a patient for an illness or injury. So we can't perform a treatment on something if they have zero symptoms. You know, you could have neurologic interference but no symptoms. If you have, you know, let's say you have pressure on a nerve and have no idea, and it's going to, let's say your spleen for hypothetical reasons, right? And now your spleen is not working properly and you would have no idea, you have no symptoms. You could have immunologic decrease often and not get sick because, you know, other areas of your body are able to compensate and adapt and overcome. But it doesn't take away the fact that it's still interfered with and that the end organ is suffering.
Just to analyze what he said there, not to interrupt.
No, I want the.
Yeah, I just want to paraphrase what Alexander said so the entire class kind of understands where he's coming from. He, briefly put that thoughts, traumas, and toxins don't cause a vertebral subluxation, but the inability to adapt to those three things is what causes a vertebral subluxation.
So the end result, though, is subluxation.
The end result via the inability to adapt.
Little man, no one likes the little man, right? But yeah, the little man, but the end result, okay.
Right.
I just had a thought right now. I'm probably not subluxated, so they don't cause subluxations.
I would agree that, like, I definitely recommend anyone and everyone to go see their chiropractor, but I was just a little hung up on the term, should everyone go see a chiropractor? I don't know, sure, maybe once every like a dentist, once every 6 months, sure, that's fine. I'm just not gonna sit here and say you should do this or you're gonna be in, like, you're gonna do bad for yourself.
Well, you as a practitioner, do you think you could help improve the quality of life of every person that you might encounter? And I say improve, not make it better, but improve, not, even if they're like, no, he says he feels great, is there maybe some kind of motor pattern that he doesn't realize that he's doing something wrong?
No, absolutely. I think we're in a great position to help people meet their goals, whatever their goals are, specifically movement based. If they want to start lifting more weight, do some sort of athletic competition, be better at their sport, and more realistically in real life, if they want to drive without pain for X amount of hours, if they want to work throughout the day without pain, if they want, or if they're not in pain at all and they want to go on a hike for 5 miles, but they don't do that right now, like we can help them do any and all those things.
So the pain, you keep on saying pain.
That can be a goal, or even if someone's not in any pain, but maybe they're afraid they will be in pain if they do activities, or I mean, even something personally that I most likely won't get into a lot, but even if someone just wants to like up their squat 100 pounds, they're not in any pain. If someone came to me and said that, I said, I can take a look at you, I can assess you, I can maybe give you some pointers, but I bet you my friend, a chiropractor, or maybe a strength coach, that either or, but chiropractors do have that ability if they want to.
Do you think that chiropractic care, be it via the adjustment or via motor patterns, can improve a athlete's performance?
Absolutely.
And they don't have to have a deficit, but it could increase their performance in some way. And so do you believe that?
Yeah, for sure. Absolutely. If you're finding quote unquote subluxations, that would be a deficit.
What were you gonna say? You had something back?
So there's like a lot of subject matter there, but like, I guess for one, like I know there's probably stuff, I'm assuming, that we've said so far already that they disagree with. So I'd like to talk about that a little bit more actually.
I want to talk about that too.
Yeah, because honestly, I agree with a lot of stuff they're saying. If they don't, I say it. But like let's say I like that comment, quote unquote subluxation. Let's talk about that.
There's just I know there's a lot of ways people define subluxation, different words they use, and I'm willing to use your word. I'm sure you have one word and one word only, and that's fine with me.
What do you mean by that?
Yeah, actually.
What do you mean by that?
I just know people use subluxation, fixation, dysfunctional joint, et cetera, et cetera.
Somatic dysfunction.
Yeah, like the insurance codes M99, right? But that's totally fine if they want to use subluxation. It's great.
How would you define subluxation? Elevator speech, stop. Elevator. What's the simplest thing you can say to Joe Schmo off the street? Person that's randomly walking up Ray Street right now. That's
Yeah.
Coming from somewhere downtown Denver. What would you say to them what subluxation is?
I would say it is a dysfunctional joint that, I mean, it's just so wide. You can use many things. It kind of depends on person to person. If I'm telling someone they have a subluxation, I can explain it that their joint dysfunction is causing suboptimal operation of their nervous system, and I think that's probably pretty good in that area.
What would you say?
I mean, we were, I guess, just curious, like, why would a joint dysfunctioning, like, be so detrimental? Like, why, in the context that we're talking about interference on a nerve, why would a joint dysfunction cause that much of an issue?
I mean, if a nerve is not operating at its optimal performance, it can hinder whatever it's innervating, which can be anything and everything, as you know.
So are we saying that there can only be a subluxation where there's a joint? I'm assuming.
To my knowledge, sure, but I'm not willing to claim that for the chiropractic profession.
Gotcha. I'm assuming you don't use the word.
Yeah, I've used it.
Oh, okay.
I don't mind using it.
Okay. Yeah, I was just gonna say, so just so everybody's aware as well, we use a pretty like delineated definition, and there's 4 components to it. It's a misalignment of a vertebra that includes a foramen, specifically the vertebral foramen, and then causes pressure on a nerve, and then ultimately results in interference on the nerve. So that is what we're assessing when we assess the patient, is we're looking for that specifically, because we know that that one thing could produce symptoms and may not as well.
To dive even deeper into that, you don't need to have, in our opinion, and what the literature says is you don't have to have joint dysfunction to have that end result of interference put upon the nerve via the pressure, pulled on or against, is what the literature says, to put, interference on that nerve, and we know that that is a bad thing always.
Yeah. Well, I want to hear what you have to say.
Well, yeah, I'm kind of hogging it
No,
here.
you're good.
I had a,
Talk.
well, alright, go ahead.
We need 4 mics is what we need.
We need 4 mics.
4.
This is Palmer. We can only afford 2.
You just raised the
Just we have
rates.
air conditioning right now.
Do you want me to
We're all
run next
sweating
door?
in here.
I
You want
guess
me
I
to see
have
if there's 2 next door?
2 questions.
We have all of them in the school right now, right here.
That's what I was gonna ask.
Yeah, I'm trying to debate on which question we want to hit you with. But my question was, how do you know joint misalignment is what causes a subluxation? And then you also said you don't need joint dysfunction. If you don't need that, then I guess how do you know there is a subluxation?
Yeah, that's a great question. So for one, we don't use the joint at all. So the joint could be malfunctioning, but there could be no subluxation present, right? Because that's just not how it works, obviously. But as well with that is when we're talking about misalignment, we're talking about the vertebra itself in reference to something else, right? So what we reference specifically in our analysis is the foramen magnum, where the brainstem exits the skull, and then we are analyzing that reference to the atlas. And based upon that, if there is an occlusion of the vertebra, then there will most likely be pressure upon the nerve, may or may not. That's why it's important to measure it. And then that results in interference. When there is pressure upon a nerve, interference is the result. And we go ahead. Yeah, go ahead.
I was just going to say that the research that he's talking about is Grostic, 1989, that states that the denticulate ligaments in the upper cervical complex can be twisted upon, putting torsion on the upper cervical complex and the brainstem coming out of the foramen magnum. So when you hear interference, and he's saying the word pressure, remember that the word pressure can be on or against, not meaning compression.
Well, let me ask you about that then.
Yeah, go ahead.
So, you're telling me it's only the nerve thing, and I'm actually I'm gonna think back. Are you saying that everything in the body needs to be symmetrical? Because you said you just talking about like foramen
Here
magnum.
we
Those are the holes
Yeah.
where your nerves come up.
So just so we're all aware as well, 77% of human beings have asymmetrical foramen magnum, meaning that they can be rotated, shifted on an angle, not a complete circle, egg-shaped as they're supposed to be, right? I mean, if the minority is an egg-shaped. But so we're not looking at asymmetries at all. That's why we're looking at their anatomy and we're assessing it in reference. Because we know for a fact when there's interference on a nerve, that is a bad thing. Like if somebody's saying that's a good thing, there's just nothing that supports that at all. No clinical expertise, no patient outcome or literature at all. Say that again?
Let's find some differences here. I feel like you guys are holding back.
No, so I had a question, and this is
Let me ask.
Okay, so you're correcting subluxations. What are you correcting when you do your chiropractic adjustments? Because you do functional assessment, but you still adjust, correct?
Yeah, absolutely. If there's joint fixation, subluxation, get that thing out of my office. We're gonna blow it up.
What's more important, the functional movement of the body or the subluxation?
It depends on the patient. N=1, man. It depends. Like
I got a question real quick. How do you know there's a fixation?
palpation
So
is usually.
I'm not trying to be like rude here, but
No,
like
no.
with
Be rude.
with
I wanna fight.
with what we're trying to do here is like we're trying to basically use all the components of like an evidence-informed practice with using patient goals, like he mentioned earlier, the best clinical research that's available, and then along with that, our clinical expertise as well. So if we're trying to use the best evidence that's available, I think sometimes like saying that you can palpate for one, a fixation, which I don't think carries much weight anyway, personally, but like even if you could, I feel like there's probably, it's probably not backed by a whole lot of evidence. I mean, there is a research study Kelly Holt did in 2015 that showed that interreliability between docs looking at intersegmental joint fixation was about reproducible 50% of the time, so flip of a coin. So, and that's just for the joint segment, not even looking at like just one vertebrae. That's like two joints together or two vertebrae together. So I think like, I'm just saying, I'm not trying to be rude, but like, I feel like that would be kind of lacking in that area, personally, just for me.
Okay. Personally, for me, like motion palpation is a super strong tool to feel when a joint needs more motion induced into it. And that's, I don't know if that categorizes as your subluxation or not, but that's when I feel like an adjustment is very warranted.
So would you guys both, would all four of you agree that, I don't agree with your subluxation definition at all. Just as much I think that you guys are lacking in yours. So, that's my personal chiropractic belief. And hopefully you guys all can think for yourself too. But within that, what is the purpose of what either one of you are doing, and how are you going to deliver it? So let's just talk about deliverance, right? You say sometimes you adjust, sometimes what is the other thing you do if you're not adjusting?
I mean, there's a lot. We can do end range loading is a pretty common thing.
What is end range loading?
End range loading would be basically a step below adjusting in terms of force in a joint complex. We can.
So is that a thrust or is that just take it to the edge and take it back to the edge, take it back? Is that how you describe it?
I think you're picking up what I'm putting down.
Okay.
No, yeah, you're right. Absolutely. It's pretty much getting the joint to end range, putting load upon it, and a reason why we do that is not just to treat, kind of like you said, it's not treatment. That's more of an assessment to see how symptoms respond. But that's another thing we do other than adjust, other things that we can do.
So when you do that, what is the mechanism you're trying to do? Or I'm guessing what you're telling me is
Sure,
you
I can.
You find it when I say, I don't think you tell me if I'm right or wrong. So you find a fixation through a certain movement pattern, and you bring it up to that fixation. And you're not taking it through to remove the fixation. You kind of bring it up to it and back off. And that either you can use as a way to check to see if it causes other issues, like other findings somewhere else in the body. Would I check?
Sure. So if you take a joint to end range, you can affect type 1, 2, and 3 receptors. Type 4 receptors in your articular joint receptors are pain modulating, and when you bring joints to end range, you can activate types 1, 2, and 3, which can decrease the pain descending modulation there from the brain. It can be super powerful in terms of assessing what joint is lacking motion in whatever direction and what motion they may need. Sometimes it can be a directional preference, many times it isn't, and they just need motion in general. And that's kind of where end range loading comes into play.
Did this happen in the extremities?
Yeah, absolutely.
So you adjust or take to the in range for extremities too?
For sure.
Okay. So not just the vertebral section, it could be other things too.
It can be, yeah. The rule of thumb we use a lot is to rule out the spine first, because it can be such a common source of symptoms and pain and dysfunction, and then kind of delve into extremities. But yeah, extremities are for sure on the table.
Do you adjust extremities?
No.
Why?
We would have to have proof of vertebral subluxation in order to adjust. So since there's
Are there subluxations in extremities?
no, it's missing a lot of the components, for one, being a vertebra, but then as well, you have to have misalignment, occlusion of a foramen, and then pressure put upon the nerve, and it would interfere with the nerve impulse as well. But another thing I did have a question as well is, you talked about you being able to feel if that joint needed to be pushed through its end range of motion in order to establish more motion in there. what if the facet orientation was abnormal? Like we discussed earlier, how there's asymmetries in the spine, asymmetries in the entire body. What if the facet orientation is asymmetrical and it's completely opposite on one facet? Or let's say with the upper cervical complex, the condyles, which are asymmetrical in 99.9% of people, if one is flatter and one is more steep and it feels like it's gliding a lot smoother and not on the other side, does that mean it needs motion introduced when there's a physical barrier stopping it?
I personally, again, I don't claim to know everyone's personal beliefs, but I personally believe that each joint needs to have competent ranges of motion in the 3 planes of motion: sagittal, coronal, transverse. And anytime I can feel fixation in either of those, any of the three, any combination or individual, that it's beneficial for the joint to be thrusted upon to induce that motion.
Even if the motion is normal because it's just a steeper condyle or facet orientation is opposite of what we're assuming?
If they don't have the motion, yeah, again, structure not determining function. If they don't have that motion at that specific facet orientation or condyle, like you said, they are gonna make up for it elsewhere. And if we can have an effect, a non-invasive effect to adjust into that, and again, like I said, have an effect on that motion, then it could be beneficial. And if it doesn't change over time, like, I don't know, a short 3, 4, 5 weeks, and if you figure out that you're not making changes with that adjustment, I'm not gonna sit there and thrust on them for the rest of their lives and hope that it'll change. But yeah, it can be a good, like, process to kind of rule things out.
We got a question here.
I don't know if this will apply to both of your groups, but like, do you believe in adjusting either top down or bottom up? Is that something that either of you do, and why?
Yeah, we look at the entire nervous system from the above down, inside out, completely opposite of the allopaths, right? They look at it from below up, outside in. It's a great question.
What she wants to know is, you look at the butt first, or do you look at C1 first?
Yeah, like I mentioned, we start at the top and we work our way down, above, down, inside out.
Okay, well, don't call me out, Pat, if I just But you don't do, oh, I'm gonna come back and follow. Yeah, what about you guys?
It can be anywhere. It depends on the patient for sure. Wherever my assessment would point to, I feel, is the subluxation that is causing their symptoms, then I would be adjusting in that spot.
So, to you gentlemen, can you get a subluxation in an SI?
The SI joint can be misaligned, but that is, as we know, a compensation from an upper cervical subluxation.
Would you ever adjust an SI joint?
How would I know that it even needs the thrust?
If it needed it.
But how?
I'm asking you if you found fixation, will you adjust it, or will you have to find something above and let the body correct itself?
There's no pressure on a nerve there, so I would never adjust something that doesn't need it.
Okay, what if piriformis syndrome?
What are you adjusting there?
Well, no, I'm asking you, it's pressure on a nerve. Or sciatica.
Neurolemma?
There's no neurolemma in the CNS and there is in the PNS. So like we said, there has to be interference on the nerve. Pain is just a symptom of having maybe irritation on a nerve, like the piriformis.
I'm talking about like decreased range of motion, the fixation.
Right, but like as we mentioned earlier, like as per the definition of Palmer, a subluxation is a misalignment of the osseous structure, occluding a vertebral foramen, putting pressure on or against a nerve that interferes with the nerve function.
Palmer came out there.
But I mean, Palmer's the one who said it, not I.
BD had his own idea of subluxation, BJ, and then BJ put x-rays in, and there was like, oh, you're a heretic, and then now we're gonna take x-rays now, and so it's like it's all part of it. So I think the profession's always think evolving, especially the use of subluxation, because then you go talk to an orthopedist, and why are you guys crazy to call it subluxation, right? It's not subluxation. So, and what I'm drilling down to is, I want them to understand your adjustment protocol and your philosophy behind what you do and how it can affect everything else. So that's why I want them to realize that you may not adjust or put thrust into an SI joint, or as we say extremities, because it's easy to say like, well, I'm not gonna risk that. There's nothing there. It's not a subluxation. Even if there's fixation or something of that sort, your focus is on the spine and how the CNS then has a top-down, inside-out effect on the rest of the body. Can you verbalize the thought process behind that and how, and let's make it simple, because we have some undergrad try here that want to know, or we have some people that always ask that question, like, that's what you scared to ask you.
No, it's such a great question. I mean, that's a question that we get all the time is, how come, adjusting up here will affect something down here? I'm speaking to the undergrad class here, as you get into first trimester, you'll take a class called CNS, Central Nervous System. And in that class, you'll learn many different things. One of those being fasciculations or spinal tracts. And we know that there's many spinal tracts that run through that upper cervical complex via the vestibulospinal tract, right? And that one in particular wants to keep your eyes level with the horizon. So if I may stand, let me explain here. When a head is tilted to one side, your spine has to compensate because of the righting reflex via the vestibulospinal tract. On top of that, we know that the corticospinal tract, another tract that you'll learn about in CNS, controls all axial musculature, even into that SI joint and that lumbar spine there, right, via the the lateral corticospinal tract. Then we can talk about things like the lateral, the lateral reticulospinal tract that also has to deal with extremities and knowing where your entire body is at, right, in relation to the ground and the world around you, working almost like a gyroscope.
Do blind people have to worry about right reflex?
Yeah, absolutely. Just because they're not able to see doesn't mean that they don't have equilibrium, and something that you'll learn about in third trimester, the saccule in the ear, right? The vestibular apparatus, something that keeps your head level no matter what, right? Babies, if you lay them on the ground, what do they naturally do? They want to roll over. It's not that they can even, maybe a blind baby, for example, he can't even see, but why does he roll over, right? The reflexes that you'll learn about. Great question.
Don't have to suck up, man.
I'm not, I'm just like,
What try you in?
I'm in 7th trimester.
Also, next round.
Sure.
For the Oscar. It's all for the Oscar.
Oh, up for the Oscar.
I'll just, I mean,
Yeah,
I'll touch
I
on,
want to hear you guys. So like,
I'll touch on that a little bit. I think both, I think what they were saying is very true and very right, but I think like going back to the N=1, the patient population that we're gonna be seeing is gonna be like, pain is gonna be a big producer of like the patients that we see. So if based off our assessments, we find a joint fixation through like the SI, our motion restriction through there, and it does need induced motion, that's kind of where we go with the idea of like applying a thrust there is good for us, and like we're okay with that.
if I want to understand. I think I talked about something. You guys heard my question for them. Do you believe our profession, our sole job in our profession, is to remove interference of the central nervous system to allow the body to work how it's supposed to?
Our sole job?
Well, I mean, like our power is ability to, through adjustments. I know we don't like all positron. I love positron. Through adjustments, through nutrition. It's always Eddie. Eddie up your voice. It haunts me. So through adjustments, through nutrition, what else can we do? Through being personable, through that, some of those things. Through, some people may go crazy, call me energy, say energy. That we as
Movement
as a
is
profession
one I would add.
make the what? What else?
Movement's another one I would
Movement.
add.
So our job and what we can use in our schools as chiropractors, would you say that from your guys' point of view, we use all those things to help N=1 or a patient or a person allow their body to work as it should be?
Yeah. why limit what within our scope of practice? Why limit what we're able to do to help the patient?
So let me go with that. Why limit yourself to?
Yeah, so I guess in order to respond properly, who determines the scope of practice?
Well, I would say the variety of Palmer and our chiropractic profession. I would say you can pretty much do what you want with it.
So you can administer vaccines in Colorado. Is that within our scope of practice?
So
I have no idea.
It is.
It is.
It is. Okay. So is would you say that's a part of it?
If
Or?
you want to go over the little thing about stupid people doing stupid things in our profession.
No, I'm not trying to go over it. I'm just trying to make sure we establish where the line is in order to know.
I would say.
Because like if it like I mean if just neuromusculoskeletal or something, whatever. What is the line?
No,
you know?
I get what you're saying. I think it comes down to, as a clinician, be a clinician first, be a care provider first, be ethical. Like, if you can go to bed at night and believe that you're giving your all to help your patient, then I think whatever you're doing is acceptable. If you're truly putting your time, your effort, and your value of what we get out of this school into that patient in front of you, then really I have no problem with what you're doing as a care provider.
Don't you think if somebody though, if like they could be jumping on someone's back with the utmost like sincerity as possible, wanting to help somebody, and that wouldn't really do anything though, right? Like it's not all about like what you like how you hope to get the patient well.
Would you guys agree? You guys agree? Chiropractic is specific, or it's not chiropractic? So jumping up on the back.
PJ Palmer said chiropractic is specific or it's nothing.
Right.
I mean,
So would you?
yeah.
Would you agree there? Would you guys agree? You specifically.
Yeah,
could
you want to be specific with your intentions of
Yeah, so
treatment, for
jumping on
sure.
the back, I mean, my kids jump on my back, it feels really good. Sometimes in a pinch, when I don't have a chiropractor to go to, I have my kids walk my back. It's not specific, but I love that endorphin feel, okay. But I will go get adjusted, or get checked. That's another thing. When your spouse asks you to get adjusted, say, hey, can you adjust me? Like, no, but I can assess your spine. And then you get adjusted. Just remember that your spouse starts saying, like, hey, can you just adjust my neck? No, I can assess you. Okay, so I'm off my marker though. So, it's chiropractic is specific or it is not, right? So, what I want to know still, and you guys have worded my question, now you can answer it.
Sure.
Why limit yourself and not adjust other joints that aren't in this vertebral area?
Right, we talk about chiropractic being specific, but before we even dive deep into that question there, I think we should take a second and talk about what is chiropractic, right? Because I can be super specific, like Alexander mentioned in the state of Colorado with a vaccination, or in the state of Oregon, a minor surgery. I can be super specific in that intent, behind the minor surgery or that vaccination in the state of Colorado. Is that chiropractic? I think that begs a deeper question first that must be answered before we can dive deep into that question. Well, I mean,
that's the
what is
little-
chiropractic?
I don't want the little things here.
What was your question? I'll answer it real quick.
Yeah, I want to know.
I mean, I can answer it, but.
Yeah.
Without talking about vaccines, we'll have to pull someone off the street that disagrees with us on vaccines. Why would you limit yourself for your technique? I want to know what's so important about your technique. Everyone in here wants to know what's so important that you don't find it a need for it to adjust an SI.
Right, I understand your question now. I think the reason that some may perceive what we do as limiting is we care so much about the nervous system and nervous system interference, and we're the only profession that can tackle that, right? Whereas in other professions, you're allowed to do other things. And as you mentioned in the chiropractic realm there, what we're allowed to do, so many other professions are allowed to do those things as well. Whereas we're the only profession that can deal with neurological interference and correcting that cause.
So we had upper cervical impairment 2 weeks ago, and we had SOT. And you guys would you say you agree with like SOT?
Honestly, I don't know enough about it.
Okay. Well, from an upper cervical standpoint, they were hell bent on saying no. You really only have to adjust the top 2 segments, and everything else below will fall in line. So are they more chiropractic sound than what you would say? Because obviously you're seeing more chiropractic sound than with them. And you might find some similarities with SOT. SOT leaves off everything in the middle, they're only up and down, and they don't really care about thoracics. Okay, it's like everything in the middle, just throw that out. Why? And this is what I'm getting. I want to pull out the why. Why, for the segments that you treat, or you
Adjust,
give attention to, why those are so important?
because
And give me the other reason
yeah.
why the other ones are not as.
Okay, yeah, so really big takeaway is that the atlas is the only vertebra in the entire spinal column that is not held in by interarticular osseous locks, meaning it can move around freely. It can actually spin around in the 360 if no ligaments and tendons and held it in its place. So that makes it a very movable bone. In fact, there's actually been, we're talking 300, 500 studies on range of motion in the upper cervical region, normal range of motion and out of alignment. And so it is proven that that area of the spine can misalign. And when it does misalign, it puts pressure on the most vital part of your entire body, which is your brainstem. The first thing that forms in the womb, and that keeps you alive, keeps your heart pumping, medullary ischemic reflex, sends all that information to your hypothalamus, the relay center that controls thoughts, axial musculature, peripheral musculature, anything. That's what it's all controlled by, is the brainstem. Brainstem controls everything. So if that area that has the most movement out of the entire spine becomes misaligned, it puts pressure on the most important area of your entire body, not just nervous system, which we know controls everything, most important part of the entire body, then you're gonna have very serious complications. And that's why there's so much research backing up Parkinson's, fibromyalgia, MS, nocturnal uresis, like anything you can think of, because that area controls so much. So that's why we choose to focus on that area. Also, we know, which we're less concerned with pain, right? Because obviously, I would much rather have low back pain than MS, for one. So like, obviously, you know, that patient is just equally as important to us, but I would hate to neglect the person that has nowhere else to go when you look up what happens when I have MS and they're like, oh, nothing. We can try to cover up the symptoms with drugs, but that's it. And there actually is a reason behind that, and we're able to help with that. Why would you not focus on that area? You know, so that's kind of more is when we're able to scientifically break down why this is happening, and then just kind of at the same time refute the opposing evidence, it's, you know, that's just not what we want to do. So obviously, like someone that has SI joint dysfunction, you would have to first of all know that that's causing the pain, first of all. And if you somehow did figure out that's causing the pain, is it being misaligned because the vestibular spinal tract, lumbar spinal tract, cortical spinal tract is all being desiccating in the brainstem, and now there's interference on it because the head is tilted, and now that my pelvis has to compensate because of my head is tilted, and now it's causing a fixation in the SI joint, and maybe that would go away if I just corrected the one thing instead of put multiple thrusts into the patient and just kind of said, well, in 3 weeks we'll see if it's better after a couple of treatments. We want to analyze it a little more specific than that. That's kind of the whole basis of it.
Would you say you're a perfect patient? I can ask you, what is your perfect patient?
Anybody with a nervous system, right? We want to make sure that everybody's nervous system is clear of interference.
Right. So, and that goes back to my original question, everyone.
Yeah.
Okay.
That's what we said. Yeah.
We know you say you guys disagree, correct? Would you ever ignore that fixation in an extremity of some sort or an SI?
Sure, yeah. If
You would ignore it or you wouldn't ignore it?
it just depends on the patient. Depends what my assessment tells me is the source of the pain. It doesn't mean that it's the site of the pain, but wherever I deem necessary is the area that needs to be addressed that's causing the dysfunction that is leading to their symptoms. It's not like I find elbow doesn't flex this far, I'm gonna adjust it into flexion. It depends.
So I'm thinking of something that plagues us all. Looking at around some of you guys here, we call it Texter's neck, right? Upper cross syndrome. Everyone heard of upper cross syndrome? That guy's just looking down his phone. It's a good south side right there. Good south side. But like, as you see, like everything in the back, we see like how the environment influences our body and how we
Yeah, the adjustment would absolutely be very helpful in putting motion into this. If we're gonna go upper cross Pacific and we're stuck like this and we have no extension, we can put extension into that joint and it can help. Now, will it be the be all end all? 99.
Can you just use an adjustment to fix that? Or do you need to do more?
You guys are gonna get tired of this, but it depends on the patient, is my answer. It can absolutely be one of the most powerful tools, and I would be quick to use it, but I wouldn't want to limit myself in just adjusting them and saying, come back in X amount of days and we'll give you another adjustment and hopefully it works.
Where's my ART backpack, girl? Where's she at? Where you at? Hey, what do you think? An adjustment fix upper cross syndrome?
No,
Why?
I just think you'd need to do more than adjustment.
Like what?
I would do exercise for it.
Exercise.
I would
like exercise.
do ART on the tight
ART.
muscles.
What's ART stand for?
Active release technique.
What does that do?
Releases the tight muscles, to put it simply. Hey, this isn't about me now.
Get on up here.
This whole, hey, this whole educational process is about all of us, right? So, are you saying that it's a tight muscle issue, or is it
I just don't think that like,
a weak muscle issue?
I just don't think that it will, upper cross is like, a combination of tight and weak, so.
Does that have anything to do with subluxations in the vertebral column?
Yeah, like it could, but I don't think that you just adjusting is going to take away your upper cross
So
syndrome.
you might need a mechanical approach, a musculoskeletal approach.
Yeah, I'd see probably something might be lacking, like stability wise or mobility wise.
So you think adjustment can't just fix that by itself?
No.
And I'll add that it just depends on the patient again. An adjustment might address someone with upper cross might have too much stability somewhere that they need more mobility. They might have too much mobility somewhere else that their body's locking down and having too much stability. It's up to you to be the clinician and figure it out.
So if someone has, I guess first let me ask you, do you believe the condition of upper cross syndrome exists?
Yeah.
Okay, okay.
No.
Or,
I'm curious, how would you treat it then?
yeah, that's my.
Well, I guess to go back to where we started, we don't treat. So we don't treat symptoms. Being that, do you know what caused the upper cross syndrome? You might know how to relieve some of the symptoms of upper cross syndrome, but do you know what caused the upper cross syndrome from happening? And I'm not saying that it wasn't posture, because it might have been, right?
I'm all with you on
Yes,
this.
but I think we're gonna be careful when we say, what was the cause of it? When we don't really know, we don't know, we will never know. But now how you treat it might change, right? Right, yeah. So we don't treat, so we're not going after the upper cross syndrome. Now, what's amazing is that all, like we said, once again, all the axial skeletal musculature, peripheral skeletal musculature, holy smokes, I can't talk, is all controlled by the relay center between the brainstem, the corticospinal tract, all that's being relayed, posture control, all those tracks that skate in the brainstem, right? So all of that and where it's at as well is being protected by the brainstem. So if there is interference on somewhere on the brainstem, that could cause miscommunication between where this is in space and where the brain, thinks it is. And then we have maybe now a movement pattern that's wrong, right? And now you're guarding something, and now you have whatever, and now you're leading to that. So what is the ultimate cause is the big thing as well. And the patient wants, once again, they're coming in because they have upper cross syndrome. They want that gone, right? They don't come in because I have nervous system interference and I want that checked. They come in because they have upper cross syndrome. So they come in and we're assessing them, testing their nervous system, and giving them the most or the best opportunity possible to deal with that, what they're dealing with. And I think the lack of confidence of an adjustment coming from you guys is because when you say adjustment, we say adjustment, it's completely different. You're not measuring the foramen, that's causing pressure, and then interference as the result, and you're not using 3D imaging to see where the vertebra is at in the first place. It's more mobilized a joint. And once again, we go back to, is the joint malformed? Is it asymmetrical? So now we're introducing motion to an area that might not even be the cause. And then we're saying, well, it's not working. Well, we didn't look at it deep enough. That's why we have to be specific and be analytical in our analysis.
What do you use to find a subluxation?
You don't find a subluxation, but
Where do you use to locate one?
yeah.
How do you know where to adjust?
how to know where to adjust? That's a great question. We, as upper cervical doctors, analyze the entire nervous system. We do that via the Titron because we know that the blood vasculature is supported by the nervous system, right? And we can use the Titron in pattern analysis to determine when to adjust, right? Now we can use, as Alexander mentioned, CBCT, the gold standard of bony imaging, to figure out, is that bone actually rotated? Is there actually a misalignment up there? Guyton Hall says it can rotate 5 to 8 degrees. We want to know that. Does it misalign? How far does it misalign? We want, we're trying to look into all of that instead of just broad generalizations.
What if, I guess I had a quick question.
Yeah.
So what if you adjust, I don't even know how to say it because you guys said you don't treat. But what if
Adjust.
your adjustment then to address their upper cross, would you say that?
That would be a treatment.
So what if whatever you're doing for the patient who has upper cross, what if it's not working? Then what?
It's a good question. So for one, I'd just like to point out that this would be a subset, so it wouldn't denote the rest of my argument. But still, if that would happen, then maybe you would look to other things and say, maybe, is my analysis correct? Do I know they need to be adjusted? Do I know that this is happening at the right time, right place, right manner, right subluxation? Is the listing correct? That is things you need to take into account. You don't just go and abandon the whole idea of how when there's interference on the nervous system, there's dysregulation in the body.
Would you guys ever refer within our profession
To who?
to another chiropractor?
Another chiropractor? I guess if you felt that that person was better suited to take care of the patient than you should. I would say morally.
And not just refer, but also co-manage care.
I mean, the end result of our care is we're making sure that the patient doesn't have neurological interference. So, I mean, if we're setting out and achieving the goal that we set out there, making sure that the patient doesn't have any neurological interference, I don't really see the need most of the time. There as you mentioned, abnormalities and anomalies, and it does happen very, very infrequently, where you might need to do something like that. But when you, as a chiropractor, set out, all right, this patient has neurological interference, and my goal is to help that patient not have neurological interference, and you would achieve that goal, why do they need to see somebody else?
What if the patient doesn't give a crap if they have neurological interference or not?
They don't. None of them do. So
You're not gonna
that's-
question that.
yeah.
Let me ask this, because upper cervical, let's just be honest, upper cervical risks is sell themselves.
They what?
They have to sell themselves.
Yeah, I would say chiropractic as a whole is
Like, we're a
definitely so.
profession, we have to sell ourselves.
Yeah.
But then within our profession, and that's the safe goal that we're in right now, where we go, we have to kind of sell our philosophy. And we have to find people that maybe either, I don't want to say sell, I hate that.
You're right though.
Find no, not marketing, that's summer class.
To make it look appealing to them.
You have to
Yeah.
find someone that
Educate is the word we use.
But you have to find someone that might also have the same philosophy as you and agrees with it, because we can talk about like chiropractic biophysics and thinking that you can go back and change, I'm not gonna say what it's basic, but like the philosophy that you can change the structure of the spine from Wolff's Law, everything that happened, and how deviations in talk about degrees of lumbar or a lordotic curve or a kyphotic curve can affect the spinal column and the spine that's within it. But you have to get people to buy in, right? Would you say that for your type of chiropractic that you love and that you live, do you find yourself having to explain yourself to other people like you are today?
To chiropractic students or to the general public?
Well, I guess it's both, because in some way, like,
I always joke and say, all my friends know, I always say chiropractic students care the least about the upper cervical region than anybody.
yeah.
Patients understand it so much. They're like, oh yeah, like that makes so much sense. And honestly, like I'm not trying to act like I'm a clinician or anything, but working in my dad's office for so long, 90% of the people that came in that had seen a chiropractor before, they're coming in because it didn't work. So they're like, oh, you're being super specific and you're using this type of analysis? Wow, sign me up. You know what I mean?
And that actually brings me back to like what I asked if you ever refer, because one of the things I'll say to everyone in here,
We are referred to a lot.
yeah, you also drop your own tore ego and realize the tick, and sometimes realize that what you do can't help someone else. That you have to look like that guy's never gonna refer to anyone. You're like, laugh. Yeah, you. I'm looking at you. You make the worst face.
I'd gladly refer. They're better than me, please.
But it's not even just better, right? It's something different. There's no better up here. There's no better 2 weeks ago when we had an SLT and circle.
I was just curious your thoughts on it. So if a patient walks into your office to get established and they've had severe trauma to their upper cervical and you can't adjust their atlas, do you feel that chiropractic would not benefit that person?
Absolutely not. So, who's deciding they can't be adjusted up there? And
Probably the surgeries.
okay,
The trauma.
Fusions.
so it's fused.
Correct.
Okay, so like what's fused and where's it fused at?
I don't know. I know.
Because what I'm about to say is gonna blow your mind.
Okay. I know C2 and 3 are fused and they had multiple breaks, and this is what he told me, they had multiple breaks to the atlas.
Yeah.
They were in
Like a Jefferson's fracture or something.
I cannot even.
Okay, yeah. So actually, Raymond Domanian, for those of you who don't know who this is, the inventor of the MRI, say that again, the inventor of the MRI, has done extensive research. What did you say?
He's a medical doctor.
Yeah, he's a medical doctor. He went to Albert Einstein Medical School in New York. He's an engineer as well. And he's done extensive research on the upper cervical complex. He actually did a lot of research on people that had fusions from C2 down, people that had insane upper cervical traumatic experiences, and were on 30 to 50 drugs a day. And under upper cervical care, well, it's mainly because of the CSF congestion that they were having, they were able to get amazing relief. And once again, this is not a chiropractor doing this research. This is the inventor of the MRI, a medical doctor doing that research. And he said it was safe and effective. So I'm not saying we do everything based on what the medical profession says at all. But what we do is so calculated, so specific, and so gentle that we don't have to worry about it because we know we're putting it the right way. We're not like, hopefully this is the right way. You know, we're like, we know for a fact this patient is better off without pressure on the brainstem, without causing interference on the anterior jugular vein, which is draining CSF from the skull, which causes CSF congestion in the skull, which causes invagination of the cerebellum out of the foramen magnum, which causes more compression on the brainstem, and then results in ataxia or whatever injuries. We know they're better off with the care we're going to give them. So that's why I struggle. And I'm not saying, you know, it's hard to make an absolute and say every single person, blah, blah, blah. But that's what's so important about what we do, and we don't take it lightly.
What's the difference between you and Yuga?
Good question. So that's an orthogonal technique, meaning that they analyze the spine and they want it in a straight line. We are a neurologic and foraminal approach, meaning that we analyze the nervous system, and that's our end goal. I would much rather have a scoliotic curve, head tilt, all this stuff going on, and no nervous system interference, than have a straight spine with nervous system interference. Does that make sense? Because that is what controls. And like you said, structure does not determine function. So that's why we don't go after that. We just believe that's the wrong area to be focusing on.
So you said structure doesn't determine function. Isn't that like the definition of physiology though? Like structure determines function?
No.
No.
Because you
Or
can.
maybe not physiology, but or maybe anatomy. I don't know.
You'll hear that a lot in school here, but
Okay.
Yeah,
I
I
don't
mean,
think
it's
so.
something I heard in like past anatomy classes too, so I was just like,
Yeah. Not to be rude, but like
our bodies are smarter than that.
Yeah.
okay, yeah. I mean, I agree with that. I'm just
Mm-hmm.
clarifying.
I'm to see any literature proving that. So,
So Alex, just a question for you, and you guys can chime in on this as well. I hear that you're frequently talking about literature that's proving or explaining the vertebral subluxation complex and the effect it can have on the overall nervous system, which is something that I'm aware of. That there are RCTs and double blinds that do prove the vertebral subluxation complex, but for whatever reason, and specifically I've had interactions with members of your club who say that they actually don't believe in subluxations whatsoever, and that it's not scientific. Just how much research is there that proves the vertebral subluxation complex?
yeah, so just to make a minor correction, we don't believe in vertebral subluxation complex, but we do believe that when there is interference on a nerve due to a vertebra being misaligned, that causes very bad outcome. as a result, and there is tons of research. I mean, we're talking literally probably, if you want to go by credibility or size of study or type of study, we could, I mean, yeah, Tyler loves research as well, so he can go off about that.
I mean, I want to open
Let me
it.
first say, like, no one really cares about the data. No one cares about tons of research and saying the word tons of research. I don't care about that right now. What I want to hear is I want students in this class to be inspired, to be able to realize that chiropractic is not the way you do it. It's not just the way you do it. It's not the way upper cervical does it. And I think more specifically with more Nuka, that we don't currently have Nuka on campus right now, and SOT. What I want to know is I want students here to identify. I want them to start to like put themselves in groups, right? And I feel like, would you guys agree that there's a large passion here on the left side, right? 100%. Yeah. Shut up, Eddie.
No passion over here, Doc?
There's passion. Would everyone, I'd say I'm more confused on what you can do. Like,
Sure.
You just keep on telling me N is 1. And
That's
I want to know more. I wanna
Okay.
know-
I was gonna say I'd have kind of like 3 main points that I kind of believe in.
Yeah, what are those 3 main points?
The one was N equals 1, so we hit that one. The other thing, another main thing we like to do is empower patients to do things outside of our office that can help reduce their symptoms. And
Like what?
well, it depends, but a lot of times they're movement based, exercises, different lifestyle advice, but there's a lot of different things patients can do for themselves in the other 23 and a half hours in their day, other than in our office, that can help reach their goals sooner and make them more long lasting to where they're not, what's that?
What's the third thing?
So patient dependence, N equals 1, and
Ed,
I'm just going through myself, Big Eddie.
shave your mustache. Go ahead. Scratch the nails though. Alright, what's the third? Yeah, what's the third? Because I have a bone to pick with Alex here. So.
My third, it's not necessarily like patient care. I just wanted to explain like what rehab to performance is, because a lot of people have a misconception of what it is, but
Please do that, because that would help explain everything.
There's some confusion out here. We want to know
So-
exactly what you do. We know what they do.
please, yeah, so this doesn't really explain like what we do with patients, but it does clear up the air that R2P, or rehab to performance, it's not a technique or anything. It's just a educational organization that provides education on neuromusculoskeletal interventions that helps treat people that are very much chiropractic patients. So they provide education on different systems to use, different analysis tools, different treatment interventions, and when to use what with each patient. And that's why I always say it depends on the patient, because it really changes patient to patient.
What are what are some of the analysis things, or what are some of the things that you use to treat a patient, like?
Sure,
what are
our
your
core,
options?
well, it's not really limited to anything. There's a lot of different systems. We have, at R2P, we have biases, and I don't speak for every R2P style doc, but again, it's not a technique, it's just a educational organization. We have biases towards McKenzie technique, DNS, dynamic neuromuscular stabilization, and neurodynamics. If you've ever heard of those 3 things, if not, feel free to ask me questions about them, but with those 3 things are kind of initial assessment tools, and then there's a lot of other things. We have a slide with like a big picture of all the different things we can learn about and use on the right patient. But again, it's all, you have to be the clinician, you get to decide what you're gonna do with that patient. It's not, don't be a slave to the methods. Don't do what McKenzie preaches on every single patient. Don't do what DNS preaches on every single patient. Take what you know from the principles of anatomy, physiology, and biomechanics, and apply them to the patient that's sitting in front of you that day. Multiple questions.
Would you say that your tool belt is very large?
Yeah, it can be.
Your Batman tool belt, we've heard that before, right? Different techniques, or you pull out techniques, or you can pull out McKenzie method. You have a lot more tools in your belt to treat this maybe the way you say.
Yeah.
And it goes one, because you're, when you say that you have a broader patient base than they could have.
I don't know about size of patient base and theirs versus ours. I think they can have a ton
Where's
of.
the ego at? I want some ego, like, yeah.
I'll be honest with you guys, I got no ego. I'm not here to say that our style's better than anyone's style. I've had multiple conversations.
Right SI area, you're like, I'll help you, they can't do anything for you.
They could probably do something for you, but I can also do something for you. It's not, no one's better than anyone else.
That's true. We don't think superiority.
You guys right. Who wants to ask?
If I may, really quick. Go.
I have a question specifically for RTP. I think there's a lot of thoughts that don't adjust, but just do like routine-based exercises.
Yeah, incredibly inaccurate.
Would you like to clear up anything based around that? I know that's not.
Yeah, that's a good point. I think I did leave that out, and it's because
Thanks, Alex, for showing up to class late.
I inherently do leave that out because it's so subconscious of me that we're chiropractors and we're obviously going to use our hands and adjust, and that's what we're here to do, and that's always such a given. And I think that's where I personally have lacked in communication of what RTP is, because that's always been such a given to me. So adjusting is, I was going to say first and foremost, but it a lot of times is because of how powerful adjusting is, but it might not be the source of the problem. Like if the subluxation keeps coming back, then maybe we gotta look into something else. Maybe we can do some movement-based therapies to keep the subluxation from coming back. I'm gonna go here.
So, I understand you guys adjust, I'm not trying to say you guys don't. But
Sure.
you guys mentioned things like McKenzie, GNS, movement-based therapies. Would you consider that chiropractic, or would you consider that a modality that you're offering for your patients as treatment?
Yeah, I mean, I 100% consider chiropractic. I think anything that affects neuromusculoskeletal systems is kind of how I've decided to define it, is chiropractic care. If we can have an effect on someone's pain, why not include that within the chiropractic scope of practice?
And I want to answer that. Well, I hear what you're saying. We also got to be careful doing it that direction, not to realize that I got friends that are PTs that will I can adjust. I know they can't. It's not specific, so it's not an adjustment. And then I got my, what's his name? He's over at the pain clinic on Maple Crest. He's a DO. I did a workshop once with him and a PT, and he's an osteopath. And let me tell you, the scariest thing I've ever seen is watching him adjust the PT. Not adjust, manipulate the PT's neck. Oh my God. Some of them, the Rindinger guy. Like, I have more faith in the Rindinger than the Pomegranate. Watching this DO just be like, I just like to go in and like do this rotational thing where it's like
Snap, crackle, pop.
like this. And I was like,
Rice
ooh.
Krispies.
I was like, that's gonna be malpractice on him. I don't know how that's going.
Doc, if I may, you hit something earlier that I just kind of want to go back. I thought it was so ingenious of you to mention it. It kind of got past. I'm getting to it.
He's
Give me a
pulling
second.
you over now.
No, I'm not. He passed over it. And that is if you don't, no, I'm not sucking up. It was a good way to put it. If you don't take anything else away today, I think the biggest take for your entire class is, you said what inspires you to be a chiropractor. I think that you should dive deep into what is chiropractic, and that will, help define your chiropractic why as you, define what is chiropractic, and that, as I think you were mentioning earlier, inspire why am I even here? What am I doing? What is chiropractic? If you don't take anything else away today, try to figure out for yourself what is chiropractic.
Yeah, and from that,
I agree with that.
And also what you were saying, or what she was saying, RTP. Adam, we'll get to you. You came an hour late.
Yeah.
I had a class.
Oh, class, my bad. Okay. Assessment is what I was gonna say. I wasn't assessment. No, but what you're saying, I want to take that. It's funny, like we talk about we talk about upper cervical, we talk about all these different techniques. I actually don't think ART, I do ART, I do CrossFit. I still use it today. Wait, I don't do ART, I stopped paying for the student website, so I do pin and release, okay? Biomedical release, or whatever you want to call it.
Pin stretch.
Yeah, pin and stretch, right? Because only if you pay to keep your certificate can you call it ART. So if that's not exactly what you pay, you else today, understand? Okay. And at least you're in the schedule, so we can find here. But the most important thing is how we as our profession look at things. Like ART can be done by, there's a podiatrist in my class, there was PTs in my class, there's that trainers, right? You can say McKenzie method, you get different varieties of different professions in there too. But the adjustment, you can say, well, manipulation in general, over any joint, that's done by DOs and PTs. And then you get in there to say, like, well, no, we're gonna be specific and say an adjustment. And the power of the adjustment, be it extremity, be it full spine, be any joint. And then you can get into it more, is like the subluxation of a vertebral, only vertebral only. And then you can get up to the where you're just talking about only doing upper cervical specific. The whole thing in our profession is that we look at things differently than those other people in those other professions. Okay? It doesn't matter what you want in your tool belt, how much you do, how little you do with the person's body that you're working with. It's our thought process. It's us understanding. Alex, you said this perfectly. That so I can say it like you did. We are the clinicians that make us. What makes us really good clinicians? We figure out what the cause. We want to figure out the cause. We can't just we don't treat. We figure out what's wrong with the person, and that could be from a systemic standpoint. We talk about like medulla oblongata or whatever, kidney. We are a full service organization in our profession. We look at the whole body as a whole, and we try to figure out why, and that is controlled by the nervous system. If you're going to do anything, you're going to fix the nervous system. You're going to let the nervous system work out. You can say how nature intended it, or you can say how God contained it, or created it. Either way, however you look at it, the system is perfect, and we as chiropractors are allowed to work perfect. Would you agree with that?
No, unfortunately.
You guys agree with that?
There was a lot there.
Yeah, we empower people to reach their goals, operate at their optimal operation. Yes, sure. I don't disagree.
You guys would say that innate controls us?
Innate controls us?
Well, not controls, but innate, how innate works in our bodies, right? It's just happening without us thinking about it.
I mean, we've given a name to, what keeps us living, right? And that's what we call innate intelligence. So a lot of people like to say, well, that's not something, whatever. You can call it whatever you want, but your body is a self-sustaining, self-healing organism, and you don't have to tell it what to do. 280 days, it'll go from a zygote into a full human baby. So you don't have to tell it what to do. And then it's funny because just a little soapbox here, but then after 280 days, now we need to help it get out, but whatever. Like,
Good point.
knew what to do up until that point, but not anymore.
Or like this.
I was confused.
When you want to get, because I think, like, why would you address the baby? Like, well, because that's the most important time is it's growing, right? The baby's not an adult, so if everyone says to you, like, why would you adjust a child? Like, they need to grow, right?
We gotta let Adam ask his question.
Yeah, this guy.
Dying out there. I can feel your doubt.
Real quick.
How's your arm feel?
Oh no, this is great. It's great. Real quick, on behalf of our HIO, I'd like to know your definition of chiropractic in one sentence. Chiropractic is.
Woo, you guys know what I'm going at, but I mean, I just want to preface with that it's not my definition. Like the people that made chiropractic are the ones that get to say what it is. If I started saying like, okay, like now when I take off my shoe, like that's chiropractic, and then I'm like, well, somebody's like, no, that's not chiropractic, because like these guys make chiropractic. Oh, okay, sorry, this is like chiropractic, but it's called the Alexander thing now.
What is it to you then?
Right. To me, I use the same definitions that the people that discovered the profession and discovered the laws of life. That is chiropractic. Chiropractic is a philosophy, science, and art, things natural. System of adjusting the segments of the spinal column by hand only for the correction of the cause of dis-ease.
You wanna say it?
No, I was gonna let them go first.
No, you
He's gonna say the same thing, dude.
I was just gonna dive a little deeper into that and say, who gets to decide what a firefighter is, or who gets to decide what a carpenter or an engineer is? It's not up to us to decide what chiropractic is. It's already been established to us, and I'm not gonna recite the definition as Alex already did.
Should
But
I ask you what a woman is?
Don't even start.
Alright, Matt Walsh.
Let's dive in.
How much time do you have?
How much time you got?
Let me take it.
I'm free all day.
Gas leave on the fire, okay?
Yes,
Do
absolutely.
not answer that question.
Are you sure?
I'll
I don't
answer.
wanna know, and I don't think anyone wants to know what you know.
Right. To dive, go ahead.
But
Well, I got. Who gets to decide what a carpenter gets to build, or who gets to decide what a firefighter gets to help somebody with? Is it just putting out fires, or are they're not allowed to help someone who's bleeding put a Band-Aid on?
Yeah, I mean,
That's a part of their job.
well,
Okay. Yeah. So what's
well, I think the analogy that was at hand was who gets to decide what it is the people that made the profession. That is something completely different, because we have a mutually inclusive profession that is philosophy, science, and arts, which means that those things all work together. Your philosophy determines obviously how you perform the art, and what the how you look at the science, how you filter evidence through your screen that is logic and reasoning. So all those things work together, whereas that profession doesn't have that. So realistically, that could completely change over a period of time. And I don't know enough about the profession to really comment on that. But
Yeah, I was just gonna say further too, like, there's obviously vast differences between us and the allopaths, and as I had mentioned earlier, what is that difference? You know, what is chiropractic? Who gets to decide what chiropractic is? We know that, as people say, it's continually evolving, but based on what?
we do. They do. I do. Dr. Weiner does. Some student or life does. Down at Cleveland College, they do. Chiropractors get to choose.
So going back to, like I had mentioned earlier, why don't you do minor surgery?
Well, okay, we can fight about that. It's everything or it's nothing, right? Well, BJ was pretty much skewered for bringing X-rays into our profession. He was a bastardized mixer, right?
Well-
Do you guys X-rays? Do you guys X-rays at all?
Well, we use the gold standard
You
CBCT,
use
which
X-rays?
which is X-ray, yes.
Okay, so well, why? That's not chiropractic.
It one. Go ahead.
Is that
well, I was just gonna
chiropractic?
say, I'm
Right?
like, no, it is chiropractic.
No, it isn't.
Yes,
It's
it is.
allopath.
What is the definition of
Did
chiropractic?
a chiropractor invent X-ray, or did an allopath person do it?
What do you say?
Did a chiropractor invent
Neither.
X-ray? Or did an allopath?
Neither. We were the first profession to incorporate in 1910, discovered 1895. Quick fact for you guys. But we incorporated X-ray, and then a lot of people left Palmer. For those of you that don't know, a lot of people left Palmer and started actually schools down the street, a couple blocks down, and they said BJ's Mixer is mixing the medical profession with chiropractic profession, because back then they were like, it's got to be done by your hands, it's got to be done by your hands. But once again, BJ Palmer, one of the developers of chiropractic, developing what chiropractic is, and he sought to use the science and said, you know what, the philosophy is that we want no more pressure on the nerve. He said, if that science can prove to us and give us a better analysis as to how to do that, then we're going to use it. Because he didn't care about full spine versus upper cervical, rehab versus not. He didn't care about that. He wanted the best outcome.
So that's chiropractic.
What do you say?
We just said that's chiropractic.
Well, no, but like I said, like that's what his goal was, right? So he used that and then used that to formulate what chiropractic is and set very specific parameters. Well, the principle of chiropractic, which is taking pressure off the nerves.
And you can only do that by an adjustment. So if someone could come up with another way to do that, that's still chiropractic then, right?
No, because like I said, the definition done by hand only for the correction of the cause of disease. So no, it wouldn't fit into that description of what I mentioned.
Yeah, I mean, I don't, my personal definition of chiropractic for me might not be the textbook definition, but again, I'm not one to
I want
like
yours.
override the creators. I think that if the creators of the profession define chiropractic that way, that's great. I said earlier, my what chiropractic is to me is helping people achieve their goals, and a lot of times their goal is to be out of pain and dealing with any pain in the neuromusculoskeletal system via any of our interventions, primarily adjusting. A lot of times movement-based therapies are incredibly valuable in that as well. Yeah.
Well, I guess just like,
Yeah, give him the microphone.
no, I guess just like going off the movement-based therapies, like done by hand, like if a movement-based therapy is still done by hand, can that be considered chiropractic? And that's not like an
Yeah.
attack at you guys,
No,
it's
no,
more
yeah.
so just like a lot of
Yeah.
people say
Well,
what we do.
According to the definition, like I had stated, it's not. So, a system of adjusting the segments of the spinal column. So that doesn't fall into that definition either. So, and like another thing, I'm like, this is a genuine question. I've actually been wondering, so I've talked about this with my
That'd
buddies.
be great. I'd love to continue this sometime too if it's getting too late.
Yeah, no, for
We
sure.
can do this
I was
anytime.
just curious if someone, let's say like, like you helped worry about patient outcomes as we, if someone has something that is scientifically proven to be able to help with like, MS, trigeminal neuralgia, nocturnal uresis, all these things, what is your mode of transmission to help? Is it to refer to upper cervical chiropractor, or like what, or do you incorporate that? I don't know, honestly.
Yeah, do I treat, or would I in the future treat like an MS patient? Probably not. I'd probably refer to where they would most likely seek care. And until you said you have great, or you have research to prove that you have great outcomes with MS or other things that you mentioned, I was unaware of that. So that would be, it sounds like an incredible referral off the top of my head.
That's great. I'm glad to hear that.
I was just gonna go off that too. I was just gonna say like, I know you guys said it too. You have no problem like referring to someone who's more qualified, more capable. And again, something that I never knew and I'm learning more about, which is awesome because we're learning more about the profession as a whole. I have no problem referring to one of you two, knowing like you guys will be able to take care of them. So
Sweet. Appreciate that.
I just wanted to touch on that and kind of add to it. Like I didn't know either. So that's something cool, like learning more.
Yeah,
Thank
I
you.
never would have thought I could have an effect on an MS patient like that.
What is your question? Because I want to, before I have to go again. Very quick from side price. What is your
Yeah, I just kind of had like a statement more than anything. Like I think a big misconception is that like just because they're referencing like the discoverers of chiropractic, it's not that they're anti-evolving the profession in any way. Like
yeah.
obviously the tools we use, like they didn't have Titron in 1895.
They were doing 30-minute exposures when they were
Yeah.
first doing X-ray.
So
So,
it's like-
now using CBCT, cone beam computer tomography, we're doing three-dimensional imaging instead of using no thermography up until 1924. They advanced it to the neurocalligraph, and then they advanced it to electroencephalo neuromantigraph, and then they advanced it now to the Titron. So like you said, the application can change absolutely because of the science, right? Because we're not going to do confirmation bias, accept the science that supports us, and simultaneously reject something else. That's super ignorant. We want to do what's best, so it's a combination between all of it. Big question.
So, if someone that does more like a rehab, like for example for you guys, if someone does more like a rehab style, just how to take care of the patients and they do more than just hands-on adjusting, is that not considered chiropractic? Even though, is that not considered chiropractic?
You mean like instrument assisted adjusting?
No, like using other modalities, for example, is that not considered chiropractic in your eyes?
Well, I don't really consider it either way because, like I said, we only really follow what was the parameters set, as in like what falls into the definition of chiropractic. So, but if you're asking me to analyze that and look at it, I can do that. But I don't really have an opinion on it. A lot of people don't know that. People think a lot of times those guys think this, those guys think that. We don't really think anything. We just follow what is the most efficient, most specific, yields some of the best results we've ever seen, like you said, and it's not even widespread. He didn't even know that we can help with MS. Oh my goodness, they should be putting that up on the TVs out there instead of cupcakes on Wednesday or whatever, right?
Stay out of the fountains.
Cupcakes.
Stay out of the fountains.
Don't mess with the cupcakes.
Was there really cupcakes? I don't know. Okay.
I think there's popcorn.
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 Yeah,
Popcorn on Wednesday. There you go.
Yeah.
Did I miss it today?
Yes.
pain. So did I.
I always, like, I don't think it's like Tuesday night. I almost forgot that. Roly, okay. Chiropractic, this is the thing I always back to you on. Because the last time I ended my conversation with SOT and upper cervical conversation about foot luggage, right? Not gonna talk about foot luggage. But something you guys said to me, and I just want to hear, I don't mean to pick the fight here, but I want to know how chiropractic sound long, okay? You say from the top down, inside out, right? And you don't think that the body needs things from the outside. Is that a correct statement?
No, but the body heals above, down, inside out.
Okay. Yeah.
But it does need, like, it needs like water and food, you know,
Yeah, yeah.
oxygen.
So, do you work out?
Oh yeah. Can you not tell? Come on. No, I'm just kidding. I know, I'm skinny.
You're very good looking. You've got a nice physique. You're in the gym way more than I am. Okay. This is all natural. Okay. So my question is, and I kind of go to you guys too, is when people work out, right? I always tell my patients that we are all athletes. Okay? I'm an athlete. He's an athlete. She's an athlete. Okay? We're all athletes, right? And we all, our body's always adapting to whatever things are on. So, from a chiropractic standpoint, and a philosophy standpoint, why do we work out if we're never going to? It's all about adaptation, right? If we're never actually going to use that adaptation.
That seems like a personal philosophical question, you know, because like obviously the reason why I work out might be different from why he works out. I work out honestly purely for like physique reasons, and then probably later in my life for more health reasons or whatever. He might work out for functional reasons, you know. So that would be like your gym philosophy. Why you do what you do in the gym, you know.
So I'm trying to tie that in, and I'm trying to pull out where people might have like different thoughts, like why don't you find what they do important, kind of thing. I think that's the thought.
I think that'd be more of a scientific discussion there.
Yeah, but some of their motor patterns, whatever the goals are that you want, right? So why don't you guys be more mean, okay? But you kind of passive about this. I want more. I want it rich.
You got nothing against it.
I can't even think of a discussion.
So, do you see health benefits in working out?
Yeah.
Yeah.
Do you see health benefits in maybe them using certain motor patterns with their patients?
Yeah.
Yeah, absolutely.
And so from that,
I see health benefits from drinking water, doing
we're
breathing
talking
techniques,
about,
whatever.
We're talking about working out though. We're talking about
Okay, working
increasing
out.
muscle mass.
Yeah,
right?
I'm sure being mobile, I'm sure there's health benefits to all those. That's, you know what I'm saying?
Right, and then I
course.
kind of go back to upper cross.
I feel like nobody says it's not helpful.
Right.
Yeah.
But then I go back to like upper cross syndrome, which is a weakness and a strength of one set of muscles and a weakness of others, right? And the only way to really kind of to fix that is to strengthen in one set of muscles that are intelligent to or intelligent.
I know what you're saying.
What is the word? One's a
Contracture?
antagonistic.
Oh, antagonistic, okay.
Yeah. So you want to do the antagonistic muscle, so there's the tone, it also causes the elements to relax, right? And you can correct that. So it's an outside thing. It's not an adjustment thing.
For the same reason that I don't adjust someone so that they look like Mr. Olympia is the same reason why I don't adjust them for upper cross syndrome. Because I'm not treating a symptom. It might help them with their goal. I'm sure getting checked regularly and adjusted when I need it and allowing proper flow to go from my brain to down to my organs, and my recovery time, my GI is working better now, my cortical processing is working better. That's gonna help improve my performance in order to look better because I'm working out better.
What would you say to that teacher who spends, young people, let's say young teacher, who spends her whole time looking down at kindergartners all day long, and then when she's not looking at kindergartners, she's sitting at her computer typing, and then she's looking at her phone, looking at TikToks, and she definitely has a, what would you guys call it?
Anterior head carriage?
Anterior head carriage, that's upper cross syndrome. You want to deliver her the best care, right?
Yeah.
can you give her the best care with an adjustment without dealing with a musculoskeletal issue?
So we want to do what's best for the patient, of course, but you have to be careful with a slippery slope as well, because where does that line end? Obviously, we're using something general like upper cross syndrome, but you could obviously take that a step further, and now they just have a little bit, and now they just kind of feel like it, and you can't really, there's no objective assessment that you can see that they do have an upper cross syndrome at all, but they feel like they do. Right now we're psychosocial. Now I don't feel good about this. Now I just can't seem to brush my teeth properly. Can you help me brush my teeth? Where does that line end? So for us to stick to what is chiropractic is a little bit more efficient, and we can spend that time elsewhere, whereas someone else, maybe an occupational therapist, physical therapist, whatever, can deal with the issues that they're more, I guess, looking for every single day. Whereas with us, we're trying to clear the nervous system of interference, which, like we said, is not the patient outcome, that is the analysis, right? So we want to use that with it more, instead of being like, okay, I'll come to your place and I'll help you brush your teeth, because that's what you want. So it's like, the point is, it's a slippery slope. Where is the line, and where that, I'm like yet to hear a line,
So if they have scaling issues from being able to anterior care, and is affecting the vein, artery, and peripheral nerve, and it's causing their arms to be asleep in the middle of the day, not just asleep. Is that something to the point where like, that's getting too far, and maybe you need more than just this adjustment right now to address issues?
Yeah, so it's important to understand, once again, that the body is adapting to things at all times, and there are certain things that you cannot prevent. So like an osteophyte that's encroaching in IVF, you'd be like, the medical professionals can say the exact same thing to all of us in this room. At what point is it too much and you need to go in there and take it out? So that's like an argument that's like a subset argument. But like you said, I would say for us, once again, is patient comes in our office, and I would be pretty surprised if we were analyzing their spine this specifically and we were not seeing the results we wanted to see. And I'm like, and there's anatomical pathways we can go through, neurologic pathways, where once again with the writing reflex, and the scalenes are innervated by vagal tone as well. So if there is hypertonicity, a lot of the time is trying to keep your head over back top your pelvis, which could be contracting and using all these accessory breathing muscles to do that. So in order to say that it's not because of that is a big blanket statement that's hard to prove.
Alright, I think we're wrapping up.
Wait, I have a question.
They didn't like that statement.
Of course you have a question.
I always have a question. So I wasn't paying attention to your name, I'm sorry, but upper cervical side, how do I say this? So you say you don't treat symptoms, but how would you market to somebody that you could help them? Because they're
Phenomenal question.
They're not gonna know really what you do.
Yeah, absolutely. So we're having a chiropractic discussion right now. This is not what I'd be saying to the patient, just so we're clear. Yeah, you can say what you help with, right? We see a lot of patients with X, Y, and Z. If there's, once again, you don't want to be making statements that's not true. Hey, we can help you fly and go to the moon, but whatever, or become a unicorn or whatever. But if there's research that backs up that specific upper cervical care can help with MS, hey, as long as you do, we see patients with MS, and a lot of them get great results. That's just a statement. And that's a lot of the times marketing people are looking for people that have good results with X, Y, and Z. And that goes back to patient outcome. Is that what we're treating? No. But our analysis has seen amazing results with that because of the principle of deduction in a chiropractic.
Alright, so I'm gonna wrap this up. I love the fact that no matter what, you guys are passionate about what you do. And I think from my class, thank you for the guests that came in, but the point is, you need to be able to discuss, you need to be able to talk to tech, you need to be able to be confident in what you say when you're talking not only to other people in our profession, but to other professions. You have to be confident talking to patients. You have to be confident talking to family if they're not chiropractors. Or that maybe if your dad is or your grandpa or whoever your maybe close mentor is, you need to be comfortable in your talking about expressing your views on things. if you have practice talking it, it makes it much easier. Alex, would you agree that you talk to tick?
All the time, every single day, and Allie like
stops. It
hates
never
it. So
stops. Never stops.
literally every single second. I actually wake up in the middle of the night and start talking about it. So
Probably why she likes you so much.
I don't think that's the reason.
Does anyone?
I'll have to tell you a funny story for another time.
It's because you're a wrestler. Wrestlers are the best, right? No hand-eye coordination. But
Yeah, see me with a ball, and it's just yeah.
I think it's really important though that not only, and would you guys also agree that you should get out and talk to people? You should have these discussions.
Our club, we go over patient and doctor education every Friday as well. So if you guys ever want to come out and just learn how to defend chiropractic or how to communicate that to a patient or a doctor, come talk to one of us Fridays at 9:20. We do it every single week.
I was just gonna dive deeper into that too. Being able to talk to tick and whatnot is so vital to what you do. And if you don't know what tick is, you should probably figure that out. That will help you so much when you're communicating to other people that don't know what it is, to figure, to help them along that journey to know what it is.
I do this thing in clinic. Some of you guys won't know this guy, but I'll walk around in clinic and I'll just be like, "This is chiropractic," and people hate it, yeah, because they can't do it. Like, you might think in your head you can say it. You're like, "Oh, I'm saying it, say it," but until you can exercise saying it out loud, and my response, they're like, "Why are you asking this question?" You're taking money for something. If my mechanic, I just actually had a brakes done on my truck today. They can explain to me why I have to pay them $400. It's because they changed the rotors, they changed the pads, the wheel off, they took the wheel in line. They told me exactly what they did.